From the presentation, you said you're able to manage people living with HIV now. So how do you do that? How do you manage it?
Right.
Can I
So
repeat the question so that it goes somewhere? So,
yeah.
So the question is about managing HIV and how do we go about that?
Yeah.
All right.
Okay. So whenever a patient is diagnosed HIV positive, we immediately take steps to bring the patient for an appointment into our hospital, into our department, and try to decipher the circumstances under which this infection was contracted. We would like to take another confirmatory test just to make sure that the first test was not wrong, and in our experience it is very rarely wrong. And then the current recommendation from the World Health Organization is that all patients who are diagnosed should start treatment as soon as possible. And this is something that we discuss with patients on their first visit. There are a number of tests, a big range of tests that we have to undertake to find out where exactly the patient is in terms of his or her immunity. We like to know their vaccination status. We like to know their general health, their kidney profile, liver profile, like for any other patient. And then we discuss starting treatment based on the results of those tests. Usually it takes 2 or 3 weeks for the results to come back, and then we can plan a proper treatment. But if it is urgent, if the patient has more serious symptoms, then we don't wait for the results. We would start treatment straight away. This is just one aspect of managing, that is the treatment. But there are other issues that also need dealing with. For instance, we would like to know whether the patient is in a relationship. If so, has the partner been tested? And importantly, that once a patient is known to have HIV, there is a good chance that this patient the infection can be passed on to sexual contacts. And so we have to limit that as much as possible. So we have a discussion around preventing onward transmission, and that there is a legal side to this as well, where if somebody passes on an infection knowingly to somebody else, then they can be subject to a legal prosecution. This is a concept that is known as, in legal terms, it is called biological manslaughter, which is something that we have to make patients aware of. And so this is all part of the discussions. We have an institution called Sahir House, which Paul will tell you a little more about it. But they offer support in terms of other things, counseling, whether the patient needs any social support. So these are the things that we would look into as well. So this is all that happens in the first visit. Once the patient is on treatment, we would initially monitor them more frequently. But over a period of 6 months, we would expect that this patient's viral load, which is the test of the amount of virus in the patient's blood, will have dropped to an undetectable level. And once that has happened consistently for the next 6 months, then we would say that the patient is not infective to anyone else. And the aim is to keep that virus at an undetectable level with treatment. And if that is possible, then virtually all patients can look at leading a normal life. So HIV is no longer a death sentence. It is like any other chronic condition like diabetes or high blood pressure, where if diagnosed early and correct treatment is started, patients can look at a normal life expectancy. Indeed, we have patients who have been very, very sick when we diagnose them, but with treatment, they are now leading virtually normal lives. They're they're working, they're traveling, they're touring, they're having children, everything that a normal person would expect to want is now possible with treatment.
Can I ask you a question, Paul? Because I'm quite interested to know what's different in your life now than your pre-diagnosis time. So, are there any changes, sort of, that really quite significant changes that you'd like to share?
Probably my quickest answer is nothing really. Apart from taking medication, for me, nothing's changed.
Wow.
My diagnosis was a bit of a shock. I probably suffered from a bit of PTSD when that happened.
Yeah.
A bit of delayed. But for me now, apart from taking my medication, pretty much everything's the same. The only difference for me is the stigma and how people react to me.
And have you had experience of that then?
Yeah, I've had quite a lot, because I'm very open about it. I've had hate messages online, death threats on Twitter, quite a lot, but that's only because I'm so open about it, and I've done, news stories and stuff like that. So that's the only really thing that affects me. It's like almost HIV doesn't bother me, but it bothers other people. My diagnosis bothers other people, especially when you're dating. A lot of people are ignorant about HIV, so you get rejected because of HIV, or people say, "Oh, that's not something I'm into," as if it's like a fetish or something. So that's the only way. It's just the other way other people treat me.
And you said before that you're working, so your employer, not a problem?
No, HIV is covered under what's the Disability Act, or I think it's the Equality Act now, so it's classed as disability. So they can't discriminate against you for having HIV. So I think it was a bit of a learning curve for them, but they have been very supportive over the years. They've given me change in shifts to accommodate medication, things like that, given me time off for doctor's appointments and stuff. So been very supportive.
That's really positive, isn't it? Really positive. Can I ask about your medication? Because I know I always thought that when you were on
antiretroviral treatment,
antiretrovirals, that there was lots and lots of medicine that you had to take on a daily basis. Do you have to take lots and lots of pills?
I take one tablet a day. I think they used to be in the early days of HIV, especially when the drugs were new, but now I take one a day. I used to take 3, but that was partly because they split the drugs up and gave me a generic drug to make it probably cheaper for the NHS.
Yeah.
But now recently I've changed medication, so I was getting a lot of fatigue and sickness, nausea and stuff. So they've changed me to a new one called Triamec, which is really good, 1 tablet a day. The only side effects I have now is vivid dreams, so really weird dreams. The other day I dreamt about that I was in a taxi with Jeremy Corbyn, and I was, it's just really strange dreams, but apart from that, it's...
Did you get a lot of things sorted?
Yeah. Well, he was telling me about all the MPs he was going to lose and stuff. I was like, no.
Do you know any secrets?
No, yeah. I felt like I should phone him up and give him some tips, but it was,
So this...
Is that quite common?
This dream about,
Dreams about Jeremy Corbyn are common, or... I know there are some medications that cause...
Question?
Before your diagnosis, what symptoms did you have before you actually went to the doctor or you knew?
Well, it's a question that comes up quite a lot, because I have sometimes people message me online and say, do you think I've got HIV? I had these or that symptoms, but I didn't have any. You get something which is seroconversion sometimes, which they say it's like a flu-like symptoms when the HIV is taking hold, but I didn't have any of that. I just went for a routine test, basically, because I have a habit of when I go into a new relationship, going for a test just in case, to get an all clear, and that's when I got the diagnosis. Personally, I didn't get any side effects. So
that's why your diagnosis was quite a bombshell too.
Yeah, my message, if everyone says to me, what are the side effects, because they're trying to see it themselves, well, just go and get tested. It's so easy, just go and get tested and find out if you've got it or not.
Dr Pandit, could you just describe, though, about some of those symptoms that people might get?
Okay. So on that note, can I first of all start by saying that most sexually transmitted infections, not just HIV, but virtually all sexually transmitted infections, usually don't have any symptoms. Okay? and getting tested is the only way of finding whether you have it or not. So when I'm in clinic, the man sitting across me or the woman sitting across me could well have chlamydia, could well have HIV, could well have syphilis, but there is no way of knowing just looking at the patient, okay? Because most of them would actually have no symptoms. That said, particularly in HIV, some patients can have initial symptoms. Soon after infection, within the first few weeks, they can have a flu-like infection or a flu-like syndrome in which they would experience all the things that you would experience in a flu, like swelling of your glands, feeling very poorly, loss of appetite, etc. Except that in the case of HIV, it tends to be a bit more longer lasting than what a traditional flu is. But otherwise, many patients would not have any symptoms at all. Now, this flu-like illness, in scientific terms, is called a seroconversion illness, which means at that point, the body has recognized the presence of the virus and will be producing antibodies which can be detected in a blood test. Okay? So this is known as seroconversion illness, but again, to emphasize, doesn't happen with everybody. It happens only with some patients. So many of them would be without any symptoms.
And do you think it would be very easy to just put that down to thinking I've got a bad cold or I've got the flu or glandular fever maybe or something like that?
Yes.
So symptoms can look like other infections.
It is perfectly possible, even perhaps natural, to ignore it as a standard winter bug or a flu or something like that.
Especially if you get better.
Yes.
You think it's fine, don't you?
Yeah.
Have we got any other questions at all?
Yeah. Well, how does it affect your mental health? How long did it take you to come to terms with your changing status?
Okay, I'm just going to repeat that stuff so we've got it recorded. So the question is, how does it affect your mental health status?
Well, I suffer from mental health anyway, mental health issues and depression and stuff, so I probably wasn't the best person to be diagnosed. But I did suffer quite badly to begin with. I found it very difficult to speak to anyone about it initially. I shared it with a union rep at work because I was concerned I was going to get sacked. But that was the only person I could discuss it with. So I didn't really have anyone to share it with. I was in a relationship when I was diagnosed, but that ended quite quickly after my diagnosis. So I was sort of on my own, which was quite tough. But I think it was more of a delayed thing, because sometimes if you don't process bad experiences, they sort of come and bite you in the ass later on. So I think that happened to me. But I think there seems to be anecdotally a bit of a link between depression and HIV. That's one of the services we offer at Sahir House is counselling, because it's not only the diagnosis, but often it can be an underlying problem with someone diagnosed with HIV. I don't know what the statistics are, but I wouldn't be surprised if there was a link between HIV and depression and mental health as well, because quite a lot of people I know diagnosed with HIV suffer from bad mental health. So
that's really interesting that you said that, because we had a previous guest speaker, and I know that was a subject he also spoke about as well, was that impact on your mental health and your well-being, which is so closely linked to your physical health as well, isn't it? So the two go together very much. And I'm quite interested, we as a sexual health service deal with the physical element, the physical side, but we have to refer on for the mental health, the counselling side, and that's where we would go to Sahir House for the support.
We're quite lucky in Liverpool as well. We've got a clinical lead for he's a psychotherapist, I think, who deals with chronic conditions in the Royal Liverpool Hospital. And I've actually been to see him and chatted to him, and he's great. It can be self-referral as well, but also you can be referred by your doctor, your consultant as well. So,
what about friends and family? At what point did you tell your family or your very close group of friends?
Yeah, I was diagnosed in 2011. I didn't initially tell many people at all. I was single for quite a few years as well, so I didn't really have to disclose to partners.
Yeah.
But I did a news story in a website in 2015, and I knew it was obviously going to come out then, so I had to tell everyone pretty much. So it was a bit of an avalanche then of people at work found out, and my family found out as well. One of my sisters is a nurse and she dealt with it brilliantly, but my other sister didn't cope well with it at all. She came out and said quite a few nasty things to me about it. Her husband was quite nasty as well. Said I'd put her children at risk and stuff like that, which is a bit odd.
It's an education, isn't it?
Yeah, but for her, it's like family, you know, you love them, but you don't always like them, you know. But for me, it was an education for her, and she has educated herself since. And actually, her husband's probably the one that knows more than, you know, anyone. So I think he's made the effort to educate, but that may be my other sister as well, talking to him and, you know, putting him in his place, sort of thing. Yeah. So we didn't speak for quite a few years, so it caused a bit of trouble in the family. But most people at work were good about it. There was a few silly comments, but majority of people were really good about it at work. So
it's like going back to Trisha's presentation before, education is actually one of the strongest preventative messages, isn't it, in terms of challenging stigma and having an understanding about how HIV works and the risks, doesn't it? That strikes me very strongly, what you're saying there.
Yeah, it's almost like I suffer more from the stigma than I do from the HIV, really. Because sometimes I take my tablets and have to think, have I actually taken my tablet today? Because I'm so used to doing it. I used to have to start having a little tray of Monday, Friday, Saturday to remind myself if I'd actually taken it or not, because it's almost like a muscle memory now for me.
Yes.
I don't really suffer from the side effects so much anymore, apart from the dreams. So, yeah, it's more the stigma for me that affects me more than anything.
So on that note, can I just mention that HIV is not something that is passed on in day-to-day life. You know, if you're working with somebody, if you're living with somebody in the house who is HIV positive, it is very, very unlikely that anybody will contract HIV through. I mean, it is sexual contact or exchange of body fluids, like, you know, using the same needles or things like that. But in day-to-day life, it is not something that is passed on. So you know, people don't have to feel scared about that. Just like Paul said about, you know, it getting passed on to children and things. These things don't happen. So education is very, very important. I did mention something about you know, counseling patients regarding not passing it further on. And I did mention a term called biological manslaughter. I'm not sure that is used now, but what is used is reckless transmission. So reckless transmission means knowingly passing on an infection to someone else, and that can you know, carry legal consequences, particularly if it's a very serious infection. As Paul mentioned, some medications do have side effects, and dreams and you know, that kind of things do happen with some medication. So we always warn patients and tell them to expect that. But that, for most patients, that actually settles over a period of time, and you know, it's not such a huge problem. Can I ask, Paul? You mentioned a dream about being in the taxi with Jeremy Corbyn.
I could, yeah, it'd be another talk about my dreams, I think. So, that's another debate.
So I mean, my question to you is, did you say that as a positive thing or a negative thing?
Well, yeah, mixed.
That is another debate.
Well, it's just, the weird thing was about it, he's starting to say the MPs he was going to lose, but they were all Tories. So I don't know, it was very weird, very strange dream. Yeah.
Do you get nightmares?
I do, yeah, yeah. But often find the nightmares are about issues I've had during the day. If I'm worried about something, they'll come out in my dreams. So I had an argument with my sister again, and that came out in my dream about her shouting at me and stuff. So.
And is that stronger since you've been on the medication? Is that something you've
I've always had it a bit in the past, but this one is like another level.
Yeah. Taking it further.
Yeah. And sometimes I have dreams within dreams, so you think you're waking up and then you're not, you're still in a dream. You think, well, I've woken up and now, it can be very trippy. Some people pay for that though, don't they? So.
A lot of
Yeah.
Dr Pandit, I'm quite interested in PrEP and PEP. It's really, have you all heard of PrEP and PEP? There's medication to prevent the onward transmission of HIV. I think it's really important to have an understanding. And I sometimes get the two of them confused.
Okay, so PEP, P-E-P, the first three letters of Pepsi, PEP, that stands for taking medication after a high-risk incident to prevent acquisition of HIV, okay? So a typical situation would be, say, somebody exposes himself sexually to a very high-risk HIV situation, then that person, within the next 72 hours, could be eligible to take medication to prevent acquiring HIV if there has been a high risk during that sexual activity. Just to give you an example, I had a patient who actually virtually came to our clinic straight from Manchester Airport to say that within the previous 72 hours, he had had unprotected sex with a local lady in Thailand. And on the plane, he panicked about HIV. And he didn't waste any time at all on landing at Manchester Airport. He drove straight to us. It was Christmas Eve, as it would be. But this is a situation where if it was definitely a high risk, unprotected sex with a local Thai girl, and if it was within the previous 72 hours, he could qualify for taking medication. So that is PEP, taking medication after a high-risk incident. There is another concept called PrEP, which means pre-exposure prophylaxis, where medication can be taken before a high-risk sexual activity to prevent acquisition of HIV. That is not currently available on the NHS in England, but it can be purchased online. And so people who think that they would be in a high-risk situation can take this medication, and in various trials, it has shown to be quite effective. There can be various situations in which this can happen. Somebody might be going on a holiday somewhere and is likely to involve in high-risk sex over there, and they can start taking it. It takes about 7 days for it to kick in. Or patients who are in discordant relationships where one partner is HIV positive and the other is negative can take PrEP in order to avoid getting HIV. So that is PrEP, and the earlier one that I said is PEP. So one involves taking medication before and the other involves taking medication after.
So, how long you should wait to know if, for example, you had unprotected sex with someone or you put by needle? How long you need to wait to know did you got HIV? Even you took a tablet, it's still a possibility you could have HIV.
Yeah. Yes.
So how long you should wait to do the test again?
Okay. So if you have not taken any medication afterwards, then the first test has to be 1 month after the incident.
Yeah. Well, if you took tablets, it doesn't do it.
No, then it is 2 months.
All right.
So 1 month after completing the tablets. So the tablets are for 1 month,
Yeah.
and then the test is a month after completing the tablets. And if that is negative, you are virtually out of the woods. It carries a specificity of over 92%. Okay? So that's what I tell patients is take a test at 1 month. If it's negative, you're virtually out of the woods. The standard test is 3 months into the activity.
Yeah, I thought it's 6.
Yeah. So the standard test is at 3 months.
So PEP and PrEP are not available on the NHS?
PEP is.
Oh, PEP is.
PrEP is not. Sorry, Paul.
PrEP is a trial as well at the moment, isn't it?
Yes,
PrEP.
yes.
It's available in Liverpool. I don't know about Sefton.
It's not
Yeah.
available in Sefton.
There's a few limited spaces apparently in the Wirral at the moment.
Yeah.
You can travel for HIV treatment as well, can't you? So, but
Yeah.
yeah, I know people, friends that are taking it at the moment on the trial in Liverpool.
Okay.
But Terence Higgins Trust, I think it was National AIDS Trust as well, took the government to court to get the trial. They've been arguing, just saying we need to roll it out. It's been rolled out in Scotland and it's highly effective. There's a clinic in London called Dean Street Clinic, and they've been offering it, they've been offering support for a long time, where people buy it online and they offer the blood tests and stuff like that, and they've been finding really good results with it. So we know it works, but the government's just been a bit stingy about funding it.
It's quite an interesting one. Sorry, question?
The young lady at the back, yeah.
How do you protect? Okay, so the question is it how can a woman who's HIV positive go ahead and have a baby safely? Okay, so it can be passed on through sex as well. How can they go on and have a baby? Do you want to answer that question, Dr. Pandit?
Yeah, so the question I'm assuming is that the lady is HIV positive, but her partner is not. And how can they then have sex to have a child? Yeah.
Or the other way around as well?
Yeah, the other way around as well. Yes. Yeah. So HIV is passed on only by the mother. So for a child to get HIV, the mother has to have HIV. It cannot be that the father is HIV positive, the mother is HIV negative, and then the mother not catch it from the father then? She could be at risk from him, definitely. Is there a possibility that she cannot catch it? Yeah.
But if the mothers, if they're both HIV undetectable.
Yeah. Yeah, medication can, yeah. So to start with, if the father has HIV, he can take medication to make his virus undetectable, okay? And if it is sustained for more than 6 months, then there is a possibility that they can actually have unprotected sex to conceive, okay? If the mother is HIV positive and the father is not, okay, the same can hold true, but also the mother can self-inseminate herself. So, that is called artificial insemination, which means that the sperm is actually introduced into the vagina and into the cervix. Okay? So the father is not put at any risk. Once the mother has conceived, then we would ensure that the mother is put on treatment to prevent the virus being passed on from the mother to the child. If the mother is not on any treatment, the chances of her passing on the virus to the baby can be as high as 40%. If the mother is on correct treatment, then the chance of her passing the virus on to the baby is less than 1%. Some people would argue it's almost 0%. Okay? So we would always ensure that the mother is put on treatment to prevent But does that answer your question, or?
So my understanding is that this would all be managed as well. So if the woman or the partner, male partner, presented as HIV positive to health services and gave an indication that they wanted to conceive, then they would be able to be supported, and that even the conception part of the child would be managed, and that artificial insemination process would be managed and supported by fertility services, gynae services. And then they have, in some areas, I know in Liverpool they had a HIV specialist midwife who would support HIV positive women throughout their pregnancy, because as Dr Pandit said, HIV can be transmitted across the placenta. It could be transmitted through the process of vaginal delivery or through breastfeeding. So there are 3 different ways the baby can catch the virus from the mum. So it's about managing the condition. And to my knowledge, and I haven't got any numbers to hand, but I heard it somewhere anecdotally, that since we've had all of those systems in place here in the UK, not abroad, in the UK, we haven't had any HIV positive babies born to HIV positive mums. So that's how good, when it's managed well, that's how good it can be, which is just really good news, isn't it? But if you think about what Dr Pandit said about how easy the virus is transmitted to mum, and we looked at that global map of HIV, and you saw the prevalence in Central Africa, I'm interpreting that that's probably the highest route of transmission from mother to baby, and that's why those figures were so bigger there.
Sorry, just to understand what you were trying to say. You see, when a woman got the virus, so the person has to already be undergoing the treatment, like taking the medication already before she can want to get pregnant.
Not necessarily.
So she can just be positive and then get pregnant still.
Yeah. But if we find that she has not been on any treatment and now she's pregnant, we would aim to start treatment by around 10 to 12 weeks.
Isn't the virus a fluid, you said? So if it's a fluid that goes from the...
It's passed through fluid, I think.
It is passed through fluids,
Yeah.
yes.
Yeah, it's a virus,
So
yeah.
it lives in certain body fluids.
That's where it likes to live.
Yeah? Would that be a correct description? Yeah. So it's when that infected fluid goes from an infected person, when it gets into the body of another person, usually through a break in the skin, that's how it's transmitted.
Make more sense if it's not a fluid.
Yeah. The virus just lives in the fluid. Yeah. Question at the back.
I have another question. Going back to what you were talking about earlier on about your biggest problem always being the stigma. Do you think the stigma has been... I'm trying to think of the proper way to look at this one.
Don't worry.
Because we're going to move away from the stereotype, okay? Because the stereotype is we used to talk about it being like a gay man's disease sort of thing, and we're moving away from that, trying to educate people. Do you feel then as an open gay man, when you were diagnosed and told people there was a bit of a gay man's thing, what did you sort of expect kind of action from people? Do you think the stigma is different for you as it would be for a straight man?
Please repeat the question.
Oh, right.
Just think for the camera.
I've got to try and repeat that question out. So I think what you're trying to say there is, we've talked about which groups in our community carry the burden of HIV the most, and one of those stereotypes we do have is of a gay man. And as an openly gay man, do you feel that the stigma is any different to you than if you were a straight guy? Is that...
Yeah, because obviously you work with other people who are positive as well, so I imagine you work with a variety of different people in different backgrounds. So you'll probably cross some of their paths as well.
Yeah. So
Yeah, we have a team of positive speakers at Sahir House, and we always make sure it's a wide demographic. So we've got, straight ladies, we've got people from BME populations and stuff. We always try and mix it up a bit, and I feel sometimes if I'm doing these things, I don't want to be the stereotype of someone living with HIV, so I'm aware of that. I have been, since a diagnosis, people have said to me, oh, it was going to happen eventually, you're gay, which is, it's not the case. I know lots of gay friends that, don't have HIV. And they say HIV doesn't discriminate, which is true. It will infect anyone if it can. I suppose it's just the behaviour that gay men do makes them more at risk. I don't know. But I think especially, I know in the 80s when the virus was first found, it was called GRID, which was basically gay disease. It was thought that only gay people could catch it. And then suddenly they started to see it in straight people and drug users and stuff. So I think people are not surprised that I'm a gay man with HIV, but like you say, it doesn't discriminate. There's people from wide backgrounds and ethnicities and everything that have HIV. One of our public speakers is a woman that caught it in a straight relationship, what she thought was a monogamous relationship. And it was only through a random test for going abroad and going to a country that she found out she had it. So, it doesn't discriminate, as they say. I hope that answers the question.
Sorry, we've got two questions going on there.
In stereo.
Do you want to say your question at the back, and then we'll come back?
I'm just wondering where it all originated from.
Where does it all originate from?
Do you want to answer that? I can answer it, but
You can answer it, go for it.
you can correct me if I'm wrong. There's theories about where it came from. I know that the one main theory that happened for a while was somewhere in Africa through monkeys and stuff, because there is a version called simian. Yeah, but then when there has been historic cases of finding people infected through HIV back even further than the 70s or 80s. So there's been historic, examples of tissue being tested and finding HIV. So I think is it probably still a debate that's going on, maybe?
Yeah. I mean, I mean, I personally don't believe much in the African theory because there is evidence that HIV could have existed, although not detected, even before that. It is true that the simian immunodeficiency virus has got certain things that are quite similar to the human immunodeficiency virus, and whether it mutated in some form. I mean, all these are theories. There's nothing to prove or disprove any of them. But yeah, it was one of the theories.
And what was your question?
What is a monogamous relationship?
Okay.
So monogamous means with the same partner. Okay.
So, yeah, you could be in an open relationship where you see other people, or a monogamous relationship. But then, as I say, every relationship you think it might be monogamous, but you don't know if the partner's doing something behind your back or something. So that's, she thought she was in a relationship with one person, but then that other person was, yeah.
like our picture, do you remember the one we had where there was a girl and a boy at the bottom and then there was all those people above? Because she thought she was in a monogamous relationship. She thought she was only with one guy and that was it. But she didn't know the history of who he'd been with and who they'd been with and all that. So
there's something we do in our training when we do the HIV awareness training. It's called 6 degrees of separation, where, actually I've got a partner, but my sexual history is also my partner's sexual history. Yeah. I don't know if my partner's honest with me. I don't know, if he says, "Oh, you're my first partner," or if he's been honest with that. I don't know, and I don't necessarily want to know about my partner's sexual history. So I find that I'm a symptom of my sexual history, but also the people I've slept with, basically. So it's a very complicated thing.
Oh, can you not hear me?
Would it feed back on the thing, or?
Oh,
will it feed back on here though?
I mean, it is.
Hello? That works.
It's to whether it feeds back on these.
Yeah, I mean, they actually have put microphones on the collar microphones, so if they're not working, yeah, no problem. So, I mean, I'm told normally that my voice is too loud anyway, but so any more questions?
Can I ask a question? It's going back to what we were discussing a couple of questions back, and that was about stereotypes of who has HIV and who doesn't. Because I thought it was quite interesting. You were saying about the stigma as a gay man, and maybe reinforcing a stereotype there, and we had a worry or concern about that. But I know it's quite interesting in our diagnosis of HIV locally doesn't sometimes fit the stereotype, and I know we've had, I don't know if you want to explain, Dr Pandit, but we've had diagnosis in our own clinical service of people who really don't meet those stereotypes that we have in our heads of who we should be testing for HIV or who doesn't need it because they're not at risk.
Yes, I mean, when patients attend our department, we undertake a risk assessment based on their history. There are several questions which would indicate whether there is any high risk for HIV or other blood-borne viruses. Occasionally, yes, we do find patients who actually don't seem to be in any high risk category, but who turn out to be HIV positive. But I think if you probe further, you can actually find some evidence that could be a high risk from something that has happened in the past. But yes, it is occasionally possible to get somebody who doesn't seem to be at any high risk for HIV, and we find that. No.
No.
No. Anybody can request an HIV test. It is a very simple blood test. You don't require a huge amount of sample for that. Really, it's very standard and routine now. All patients who attend our clinics in the sexual health service are offered an HIV test.
Got a question over here?
How do you test a baby for HIV?
How do you test a baby for HIV?
Well, it depends upon how old the baby is. So there are various tests that can be done immediately after birth, and there are some tests that can be done up to 18 months. And typically, if the antibody test, which is the standard test that we use to check, if that is positive beyond 18 months, then there is a good chance that the baby is HIV infected. Because if it is the maternal antibody that is showing up positive, most babies would lose it by 18 months. So, but there are different types of tests. There are some that test for the virus. There are some that test for the antibody.
Okay, question at the back, big voice.
Yeah. Do you know when you go to like the homosexual health screener, is that automatically included there?
It is offered, yes. So there are some tests, for instance, there would be a swab that would be for gonorrhea or chlamydia, or a urine test. And then there would be a discussion around a blood test, and all patients would be offered a blood test, which would be for HIV and syphilis at the very least.
Question, do all pregnant women get offered the test, or is it compulsory that they have it?
It is, all women are tested for it. Pregnant women in this country are tested for HIV, unless they opt out of it.
Another question.
Why don't we just go and test everyone now?
Why don't we just go and test everybody?
Can't force people. Yeah.
Number one is you can't force people. Okay, so today I can't just say that, okay, half of you can go home, but by the way, half of you are not going home unless you're going to have a blood test. It doesn't work that way. The second is that actually, if you look at it, the incidence or the prevalence of HIV in the UK is actually quite low. It isn't a high-risk country. Okay, yeah.
Why don't we just like start doing it like colleges or schools?
Like when they do the vaccines, why don't you just do them as well?
It's a good question.
So are you saying when we do drop-ins,
Yeah.
we should do drop-ins and do HIV testing?
Yeah. We'll give them a choice.
Or agencies that support with that as well. We could probably do it through Sahir House as well.
Yeah, and some outreach does the finger prick test. So
Yeah, we
you're
do it in
seeing
Liverpool.
a lot of stuff about the finger prick test, which is what they're promoting awareness about, where you just do a spot of blood and people can get an answer within, I think it's 5 minutes or something like that.
Yeah.
It's very quick. And you can order them over online. You can get them posted to you as well to do self-testing
can
kits
do it
at
at home.
home if you want to. The best test, the most accurate one, though, is the ones that we do in our clinic still, the proper big blood test. But you can do a finger prick test also. And I think the reason why we don't just test everybody is down to what Dr Pandit was saying. We're dead lucky because it is still very low prevalence in this country. So probably someone's done a sum adding up how much it costs to test everybody compared to the number of people that they think they're going to find positive. Instead, what they tend to do is get the money and focus on targeting it to specific groups or specific areas where they make it available. But I hear what you're saying. Yeah, why don't we just test everybody? Because we vaccinate everybody, don't we? Yeah. Question at the back.
What are the specific groups more likely to be infected with HIV?
What about them?
Who are they?
You mentioned about specific groups more prone to infected with HIV. I just wanted to ask, what groups are more likely?
So yeah, gay men or MSMs. You see, we don't like to use the word gay in our clinic. It is kind of a bit discriminatory. So the scientific term is MSM, men who have sex with men. So this is a high risk group. Bisexual men is another high-risk group. Intravenous drug users is another high-risk group. People who are having sex in high-risk sexual areas of the world is another high-risk group.
Sex tourism, I think, is that
Sex tourism. And yeah, so these are the main groups.
And we find men from this country travel to certain parts of the world to have sex, and surprisingly as well, women from this country travel to other parts of the world also for relationships and sex, and both those different parts of the world are of quite high prevalence. So that is quite a high risk thing. I'm thinking of the just like you were saying about Thailand before, and sex tourism and things like that. Got a question at the back? Yeah.
Sorry, not just a general issue. I'm old enough to have been around when the AIDS epidemic came, and obviously people have very stereotypical views. How do you target and educate that area of people who will be still stuck in very discriminative ways or passing false information down to the younger generation?
Through young people. We
This.
have to do things like this and hope it goes back that way. Yeah. I was just going to say, I have been in sessions with students where I've had comments that, well, my dad said or my mum said. And it is a generational thing, because you're right, in the 80s, probably there's not many people in this room actually remember this, but there was a big campaign, Don't Die of Ignorance. Yeah. And you can actually YouTube the Don't Die of Ignorance campaign, and it was a very, very dark, scary, public information advert, basically. And every household also had flyers put through the letterboxes, and it was very much about a scare thing. Now that has stayed with the older generations, and unfortunately it is trickling down, so we need to challenge it with you guys. Paul, do you want to add to that?
Yeah, I actually went to an event once in London with Norman Fowler. He was the health minister at the time when those Tombstone adverts were run, and he said it was of its time. We didn't know a lot about HIV when it came out, or GRID. We needed to react. We know people were getting it, and it was about Don't Die of Ignorance was the campaign. He said now we wouldn't do something really similar, but at the time it was, it was useful and it had its place. But I grew up I was born in 1980, and I grew up with those adverts. I remember them, and that was my first thought of HIV. It was, a very scary thing. But now I know I'm going to live a perfectly happy and normal life, and I can't pass it on to my partners. Things have changed, but the attitudes and the stigma hasn't. So that's why I say I suffer more from the stigma than I do from the virus sometimes.
Do you find that you suffer more from the older generation, or through your social media when you're trying to, give practical information and guidance to anybody in any age who's got and what and listen to your podcast?
Well, we do awareness training at HIV, a bit of a shout out and a plug there. We do a lot with healthcare professionals as well, which is really useful, because even though people are nurses or doctors, they might not know everything about HIV and working with people with HIV. So we find those are really important. But I find a lot of the younger generation now are a lot more open and willing to learn about it. But a lot of the older generation, I find, are stuck in those 80s adverts, and unfortunately.
Well, let's question. You guys are the educators of the future. So now that you've got all this information, you can challenge away at any stigma you ever hear. Question at the back. Okay, so if your HIV goes undiagnosed, how long will it be before you start to feel poorly and unwell, and you might
develops
into AIDS? So
it
develops into AIDS, was it?
Yeah. Untreated HIV over a period of time, typically around 8 to 10 years, will land a person into a very severe state of immune deficiency. At that point, it is possible that the person may contract various other infections, which normally would not happen in somebody who has good immunity. And that end stage is what is called as AIDS. So untreated HIV in the majority of patients will land into AIDS in about 8 to 10 years' time. There is a small group of patients, about 5%, which are called slow progressors. And nobody knows the reasons behind that, but basically nothing happens to them for years and years. But for the majority of patients, yes, that would hold true. But the good news is that with treatment, now we are actually seeing very, very few patients, if any, who are landing into AIDS.
Can I, Liz, sorry to interrupt, can I just interject? There's a young lady at the back who's been dead to a patient.
She keeps putting her hand up, bless her.
Go on.
Can gay women pass it on to each other?
Can gay women pass it on to each other?
Well, it depends upon what they do, isn't it? So, I mean, remember, it is passed on through any act that involves exchange of body fluids. And there are some body fluids that are more infectious than other body fluids. So in theory, the answer to your question is yes, they can. In practice, it is probably quite low because, as I said, a lot depends upon what happens. To be a bit more blunt, penetrative sex between two females usually would not happen unless they used sex toys.
And it would be through that body fluids from sex toys going from one person to the other. Yes.
But otherwise, it is very unusual because otherwise most women would resort only to either stroking or fingering or nothing that involves penetration, and so the chances would be significantly less. Yes.
Can I just say, if anybody's going to work in sexual health, you have to get used to saying these things.
Yeah, absolutely.
We've got, you wanted a question, and then we've got another
and
student over
back
here,
as well.
and someone else in the back.
It's low. People like in the UK have got AIDS, like full-blown AIDS. Do we know statistics on that? How many are like diagnosed with AIDS today in society?
Well, there are about, I think, 50 to 60,000 people living with HIV in the UK.
Do we know how many have gone on to have AIDS from that?
Very, very few. I mean, I don't have the exact figures with me, but if you go onto the public health website, they will actually show you that the percentage of patients who have landed into AIDS has gone down significantly after treatment was introduced.
You also say within the activist community that we shouldn't be seeing AIDS now. With early diagnosis, we shouldn't have any need to see it. Correct me if I'm wrong, but often it's a thing with late diagnosis. Yeah. I had a friend that was diagnosed late and he had AIDS and a lot of complications, and now he ended up having a stroke. He walks with a limp and stuff, but that was because of late diagnosis. We shouldn't be seeing that in one of the richest countries in the world, unfortunately. That's like a completely another debate why that is happening. But the government are saying they're aiming now, and Liverpool is a fast-track city for 90% of people should be tested, 90% of people should be on treatment, and that means those people aren't passing it on anymore. So if you get straight onto treatment and being tested, you shouldn't be passing it on. So we have the tools in the UK to get rid of HIV, but we're still seeing people diagnosed, which is a shame.
Because I know we work for Sefton, but I know in Liverpool there are pledges that they've had to join in and do on a worldwide level, haven't they, about actually reducing the transmission of HIV, and it's really quite some big things they're signing up to, isn't it? Really quite radical. Yeah. Right,
I was going to say we can only take 2 more questions now. So we've got a student here who wanted to ask something. Yeah, it's yourself, wasn't it? And then was there somebody at the back? And then we're going to have to draw a close, unfortunately. Thank you anyway. Okay, sorry. So if it can be passed through bodily fluids, which it can, why can't it? Through kissing? Right. That would be gallant.
Yeah, because some body fluids are quite infectious, like the blood and semen, and some are actually very lowly infectious, like the saliva or sweat or the urine. So these contain very, very low levels of the virus, and that they are not usually enough to cause an infection in somebody else. And that is why one of the slides that was shown by Trish in the beginning was to show the fluids that are mainly involved in passing HIV, and they are blood, semen, vaginal secretions. So these are the main ones. But things like saliva or sweat or urine, they are. So it's very unlikely that somebody will catch HIV from a toilet seat, okay, that is contaminated with urine. Very, very unlikely.